Good afternoon, everybody. Welcome to this. Good afternoon, everybody. Welcome you all to this afternoon's combined round from the Department of Cardiology, and then after that from the Department of CTVS. We had a interesting case where invasive percutaneous fetal cardiac intervention was done for the first time here, and that case we are going to present. Dr. Ramakrishna and his team is going to present that.
Yeah, after that, what Dr. Rama will talk about before birth, and after birth, the department of CTVS will talk about an interesting case. Thank you.
So, good afternoon, everyone. It's a proud privilege to present to you the first fetal cardiac intervention done at our institute. I think it was a collective teamwork of Department of Cardiology, and a great amount of effort went in with the team from fetal medicine headed by Dr. Vatsala and Dr. Aparna Sharma, and along with the team from cardiac anesthesia. I think our resident and assistant professor in the making, Dr. Lamak, will present the case.
Very good afternoon to all my teachers and colleagues. Today I'm standing here in front of you to discuss a case, a complex procedure we undertook at our center in association with the Department of Obstetrics and Gynecology, the fetal medicine unit of it, and the cardiac anesthesia team. It is said that if you want to seek answers to things in the future, look back deep into the past. That's what exactly forms the base of our procedure today, where we were trying to avert this dreaded endpoint called hypoplastic left heart syndrome. So any obstruction to the left ventricular outflow in the form of an aortic valve obstruction would, over the course of gestation, lead to underdevelopment of the left heart structures so that they will be incapable of supporting the circulation after birth. This anomaly is rare, but it is nearly 100% fatal in all children by 6 months of age. Even with all the surgical advances that we have, these patients have a poor outlook. They require 3 major heart surgeries, in which we really recruit the right ventricle to overtake and take over the function of supporting the circulation, which it is not designed to, and neither is it able to sustain the same. That is why what ensues is very high mortality during the stage 1 surgery and very high interstage morbidity and mortality. Despite these multiple corrective surgeries, even if they are technically successful, what we look at is a life expectancy curtailed at 15 to 20 years of age. And putting this to the Indian scenario, it is highly impractical and resource intensive, and therefore finds itself low on the priority list. In fact, this remains only one of the cardiac subsets which even we as a department avoid to undertake. Going forward, can we change the course of the fetal heart development? Is there some room to intervene? I would now like to request my colleague from the fetal medicine unit to explain the case to you.
Good afternoon, everyone. The patient presented to us she was a 26-year-old mother. She presented to us at 26 weeks period of gestation. She was gravida 4, para 1, 2 abortion, and no living issues. The first pregnancy was an intrauterine pregnancy, and she aborted at 2 months of gestation. It was a spontaneous abortion. The second was again a spontaneous abortion at 2 months of gestation. In the third pregnancy, the baby, it was a full-term normal vaginal delivery, and the baby expired at 20 days of life. The exact cause of fetal death was not, the neonatal death was not known, but there was an ultrasound scan which was suggestive of arch hypoplasia. The fourth pregnancy was the present pregnancy. In the present pregnancy, the NT-NB scan was done at first trimester, which was normal. The dual marker was low risk. The anomaly scan, which was done at 18 weeks, were almost normal. There was just echogenic intracardiac focus, no other congenital malformations in that level 2 scans. The patient presented to us at 26 weeks, in which the fetal echo findings were severe aortic stenosis, dilated left ventricles, dilated left atrium, moderate mitral regurgitation, and left ventricular dysfunctions. Then we referred the patient to Pete's cardio teams to do the fetal echo, and there are the findings.
So what we found was a critical aortic stenosis. There was nearly no flow across the aortic valve. It was almost bordering to the levels of atresia. Along with that, what we can see is the other left heart structures were already much below what was expected of age. So this was in a way evolving towards the hypoplastic left heart syndrome. So now what was the way forward? Medical termination of pregnancy is usually the default option across the world. But in the present scenario, this was a precious child. The parents did not wanted to continue the pregnancy. The next was to just wait and watch, let the child be born, and then tackle all the neonatal issues and the surgical issues. Even that, as discussed earlier, we are not looking at some bright future outlook. So next was, can we go in and dilate that valve? What if we go in and dilate, and what if the structures grow? So that is where we constituted our fetal team, and we went ahead initially to counsel the parents.
So for counseling the parents, we conducted a fetal board meeting in which we explained the patient about the procedure, what exactly the condition of the fetus is. Then we explained the complexities of the disease, and then we explained the procedure to the patient. At every point of the time, we always gave the patient the option of medical termination of pregnancy, since it was a new procedure and we are not routinely doing it, and the prognosis of the fetus, if it develops the HLHS, is very poor. So then we explained why the procedure was necessary and what are the outcomes of the procedure, what is the success rate, and what will happen if we don't do anything. If the patient develops the HLHS, the prognosis, we explained to the patient that it is very, very poor. The alternative options, MTP, even if the procedure fails, we told the patient that even if the procedure fails and we are not able to revive, then in that scenarios, the MTP option remains open for the patient. We counsel the patient about the complications that we were anticipating. In the fetus, there could be intrauterine death, bradycardia, hemopericardium, and the risk of premature delivery. For the maternal risk, there were chances of preterm premature rupture of membranes, very rare chances of infections. The fetal position was very, very important. So this was a very important point when we were counseling the patient, that there might be a chance that we don't get the fetus in that specific position in which we require to intervene. So we explained the patient, suppose if the fetus is not in that particular position, that we might have to postpone the procedure, or we might have to repeat the procedure if the fetus doesn't allow us or doesn't give us a specific position to start our intervention process. For fetal anesthesia and paralysis, we use fentanyl injections and injection vecuronium intramuscularly.
So finally, we came to this magical procedure of in utero aortic valve modification, where the needle has to reach the fetal heart, traversing through multiple layers across the maternal abdominal wall, then the uterine wall, then the fetus's chest wall, the fetus's left ventricular wall, and finally it would reach the cavity. And from there onwards, we would have to thread the balloon across the aortic valve and dilate it. So after counseling the parents and obtaining their consent, we planned the procedure. We took in the anesthesia input for maintaining highest safety for the mother, and we did multiple in vitro trial runs with all of the hardware so as to avoid glitches during the actual procedure. And last but not the least, we anticipated all the expected glitches and complications that could occur and rehearsed their management. So what exactly were the challenges that we were expecting? As my colleague pointed out, first was the optimal position of the fetus. The second is that what we are trying to fidget with is the size of a grape. The left ventricular size is only 20 millimeters, and there is no dedicated hardware for this. So we actually borrowed hardware from our adult counterparts, the coronary hardware, to perform this procedure. As far as the operator's skill goes, so there was a requirement for astute precision on the operator's part, because what we were looking at over here was margins in millimeters of here and there. And finally, as soon as the left ventricular cavity is punctured, it collapses and it disrupts all visual feedback, literally relying on the operator's tactical feedback to thread the wire across the steno's aortic valve. It is akin to like threading a needle blindfolded. Finally, the needle piercing the heart will not give you more than a couple of minutes to do your job and then get out. And with all this hula hoo and adrenaline rush going in the background, it required mental steadfastness from the operator to keep his calm and avoid the glitches. So we as pediatric cardiologists are actually tuned to performing this procedure through the major vessel of the lower limb. But what we had over here was the lumen of an 18 gauge needle which stretches to less than a millimeter. So we repurposed all coronary hardware. We took coronary balloons, coronary wires to execute this procedure. Finally, moving on to the day of the procedure, I'll now introduce my anesthesia colleague to give us their inputs.
Anesthesia challenges for us were twofold. First, the non-operating room anesthesia, which is not our usual the OT room environment, and second is the maternal concerns, which were the as the patient was second trimester patient, so the cardiovascular and respiratory changes which happened with it were also of concern to us. So the maternal cardiovascular stability during the procedure was of prime importance for both the safety of the mother and the fetus. We chose maternal conscious sedation as the mode of anesthesia. For maternal monitoring, we employed ECG, NIBP, SpO2 and capnography, which measures the expiratory CO2 levels. For fetal monitoring, we had the real-time USG the real-time USG fetal movements to measure the fetal heart rate. For maternal anesthesia, we had IV sedation, oxygen was supplemented, and we gave infusion dexmedetomidine infusion and fentanyl bolus of 1 microgram per kilogram. Now, the transplacental transfer of drugs, placenta forms an important barrier and a link between the maternal and fetal circulations. So the fentanyl which we gave to the mother has a little passage through the placenta, which we think that could have supplemented the fetal intramuscular injection. The other drug was atropine, which was used. It has a high feto-maternal concentration, so we gave IV maternal atropine with the target being the fetus, so that it passes through the placenta and we could treat the fetal bradycardia, which happened in the procedure.
So let's see the magic unfolding in the next 90 seconds. So our fetal medicine team, they initiated the transabdominal entry. I would now.
When we examine the patient on OT table, actually, as we have told, that the most important part was the spine should be posterior and the heart, the apex of the heart should be pointing upwards. But when we did the scan, the heart was in lateral position. The fetal heart was pointing towards the lateral side. So to attain an apical position, we actually had to do an external cephalic version of the fetus. And in that verted position, we give the intramuscular injection of vecuronium and fentanyl to paralyze the fetus. And then after that, through the 18 gauge Chiba needle, we pierce the skin, then the subcutaneous tissues and the uterine wall. And then after that, through the transthoracic route, in the transthoracic route, the Chiba needle, we pierce the left ventricle and we kept the needle near the left ventricular outflow tract. And when we are near the left ventricular outflow tract, that is the origin of the aorta, we hand it over to the peds cardio team.
So as soon as the LV cavity was accessed, we started seeing a pericardial effusion coming up. And at this point, we realized that we were running against time, because as soon as this effusion starts developing hemodynamic instability, we were done. So we immediately, the operator, as soon as we removed the stellate from the needle, the LV cavity collapsed and all visual feedback was disrupted. And the operator, just with his feel of the wire passing through a stenos valve, crossed the aortic valve. Now, as soon as the aortic valve was crossed, you can see the fetal heart coming to a standstill. It just signifies how tight the stenosis was, that a wire which is barely thicker than the breadth of human hair was actually plugging off the opening. So to resuscitate the fetal, the only access we had was the needle, but the lumen of the needle was occupied by the wire. So we didn't know how to go about. So we went through the maternal route, we gave the mother atropine, it crossed the placenta, the fetal heart started beating again, and quickly the balloon was threaded across the aortic valve. By the end of the minute, we had reached where we wanted to with what we wanted to. and the balloon was inflated. Over the next 30 seconds, we gave 3 inflations, and then the moment where we could appreciate the flow. There was mild regurgitation as well. The pericardial effusion started regressing. We carefully removed the entire assembly. All this while the fetal heart rate remained stable. And finally, this is the image showing the image to your left is the one before the procedure, showing no flow across the aortic valve, and to the right is the one after the procedure, which shows the colorful specks of blood flowing across the aortic valve. The mother and the fetus had an uneventful recovery. There was no further progression of pericardial effusion during the ward stay. The mother was delivered tocolytics and progesterone pre and post procedure to avoid any preterm labor due to uterine irritation. She was discharged on day 5, and on her first weekly follow-up, the flow in the aortic arch still remains strong. This is only the second center in the country to perform this. Prior to this, only 3 cases have been done in the country. Less than 200 cases, such cases have been done worldwide, and almost more than 2/3 of them coming from US and Germany. And in toto, it has been performed in 7 countries across the world to the best of our knowledge. One point to be noted was that everywhere else, this was done with dedicated, high quality, expensive hardware. And even in one of the highest volume centers at Boston, none of them had technical success in their first attempt. Going back to the outcome of these patients, so technical success is usually achieved in around 70% of the cases, and about half of them actually going on to developing having a biventricular repair, which has been also been pointed out again by the center in Boston, who studied and followed up these almost 100 patients up till their postnatal stage, and fetal demise rate is around 20%. So here we are, this group of mortals who are now waiting for the divine intervention to translate our technical success into a physiological success.
Thanks a lot. And it was a truly teamwork. I think it culminated into good outcome. So we were all prepared for the one. And the most important thing that I realized was the teamwork, and as well as the amount of effort went in to explain the procedure to the parents and getting the informed consent and preparing for all the areas where that could be lacuna and where it could be altering. And one thing that happened was, as soon as the fetal bradycardia was happening, almost everybody in the room had heart rates which are equivalent to fetal rates. So maybe I'll now call upon Dr. Vatsala and Dr. Aparna to share their comments, and before it opens for discussion.
Congratulations. Congratulations. I think it's a landmark intervention and a step moving forward in the collaborative effort in the field of fetal medicine. And I think we will go ahead and do many more. We're already collaborating with them for fetal echo and managing the patients. So definitely that's good work, and we look forward to the outcome after the baby is delivered.
Thank you. Maybe some comments from Dr. Saurav, who was, Dr. Aparna, you want to say?
I just want to say that we have a very good collaborative team with the pediatric cardiologist, and I think that was the key in actually planning this and being able to do this, because on almost a daily basis we are able to collaborate and say whether this needs. So this was the first case which actually we thought from both sides that this is suitable for intervention, and I think that is what really reached to the end point. So I think the collaboration was great, and we worked like that in the day-to-day life. So thank you very much.
I think Lamak presented it so nicely. It became quite clear. The procedure is quite complex, and when we were on the table, it looks like as if we have spent some 5-10 minutes or maybe more. But then when we look back in the echo machine, then only we realize that we spent only 90 seconds in going in and coming out. So it was all because of the prior preparation, and I think for any such procedure, we should be doing a lot of preparation, because 90 seconds takes a lot of preparation before that. Then only we can succeed in such procedures.
Some comments from Dr. AIIMS, who coordinated the anesthesia team.
I think it was a very nicely conducted and nicely planned procedure. And as far as our role was concerned, was all about eternal vigilance, eternal vigilance. And our dedicated support team, our residents have played a very good role. And we are always vigilant, and that comes to the role of our vigilance all around. Not only the monitor, even the echo machine, the fetal echocardiography, the loops have to be all closely monitored, and you have to act in split second. Thank you very much.
I would like to thank our residents, Dr. Satrupa, Dr. Lamak, and Dr. Gaurav, who were there in the procedure throughout. Almost for the week, we were just thinking about this procedure, and I think the whole fetal medicine team. So maybe some comments from sir before it's open for discussion.
I'll just add one point. First of all, I just would like to add that we have a director who's a pediatric surgeon. So today both the cases are pediatric cardiology and pediatric cardiac surgery, because that's the first CCR we are presenting in his leadership as far as cardiology is concerned. The point that I wanted to emphasize was that we are dilating the aortic valve at 12 atmospheres pressure. Now, what is 12 atmospheres pressure? Anyone would like to tell how much is the pressure in your car tire?
2 atmospheres.
So, in your car tire, the atmospheric pressure is 2 atmospheres. So, we are using 12 atmospheres pressure in this child to dilate the valve. So, that is the amount of pressure that is being used to dilate this valve. So that is an important point to remember. And I think it is all about desiloization and everyone working together as a team, which is congratulations to everyone, whether it is cardiology, whether it is cardiac surgery, whether it is cardiac anesthesia, whether it is fetal medicine, whether it is, all the departments have really worked together, and imaging. So congratulations to all.
Any comments and discussion, like anything?
Could this have been done in the OT instead of the could this have been safer done in the OT?
I think it can be done anywhere, but I think as cardiologist, I think giving anesthesia in cardiac cath lab is now a routine. Like almost we do it every day for our various procedures, so that's not a big issue. So the issue was that for about our comfort, we discussed about this also, but we were more comfortable in doing it in our cath lab because suppose some hardware doesn't go, we want some other hardware. All those things were reaffirmed. It's about our comfort. That's all. I think they offered us to do it in the OT also. So
the other question which I want to ask the gynecologist is that they have repeatedly used the term MTP. At 28 weeks, MTP?
Yes, according to the new MTP law, you can offer MTP anytime when the fetus has significant cardiac anomaly, and this is a severe one.
This is recently been
Sir, just for the interest, I just want to know who performed first in India.
in India, it was done by Dr. Nageshwar Rao and his team in Hyderabad. So none of the 3 kids are actually alive right now. That's what we heard from him. And then when we discussed with him, he said it's very difficult to do. You may not succeed, and if you require, I will come. That's what he said. So then we thought we'll go ahead and see what happens.
Do we have a special hardware for this?
So they apparently in Boston, who are the largest work, and they apparently use a specific balloon which is made from thermo ink, which actually goes through this 2.4 French, like it needed 2.4. It's a very, very miniaturized balloon. Only this balloon went through this Shiba needle. So the other balloons, the routinely used coronary balloons also don't come out of this needle. So that was the problem. Like we have to waste at least 2-3 balloons, because once you get the balloon out, then there is no way you can pull it back. So they used a specific balloon which could go in and come out.
It's very difficult to
Organize such things like.
So we also actually we did try it once. The baby was not in position. The balloon did go in the needle. So we thought, okay, we'll come back again. We didn't sort of persist, but we wanted to do it in a perfect way, so that the chances of success are higher. So this was the second time we did. First time we abandoned, we didn't go ahead. The second time everything was in place. I think Dr. Ramamurthy may not have preferred to get the proper balloon and everything.
The size of the balloon?
So 3.5 millimeter into 15 millimeter.
Even 4 angle balloon was so
very specific. 2.4 French is the maximum size that can go there. Larger balloon won't go. Larger length will go.
So for the cardiologists in the group, the complaint balloons were only going and the non-complaint balloons were not going. Like, so it was extremely difficult, and we thought of using stripped stent balloons. They also didn't go. It was only very specific companies, very high profile balloons that could go in and come out. Nowhere else. Like, you can't enter, like you have to enter through the LV. Like.
I think this would have had a perfect position with placenta as well.
Yeah.
That is not mentioned. Yeah, exactly.
So that's
Conducive.
why initially when we were trying to do the baby was also like kind of spine anterior, but it was kind of rotated, and then placenta was away. So eventually when we are going through the most of the procedure, we try to avoid the placenta, but it's not like an absolute contraindication, because we just look at the vascularity to doctor, and if there are no vessels in the way, we go through the placenta also. That's not like the biggest contraindication.
And the hemocentral was decompressed during the...
No, there's not one.
Usually it happens in all such procedures, but once we dilate it, it gradually goes off. It happens in many neonatal
ये कैसे आएगा?
Good afternoon, respected teachers, seniors, and colleagues. Today we are here to discuss a case of left ventricular diverticulum as part of Pentalogy of Cantrell, which required a multidisciplinary approach. And I am Dr. Pradeep from CTVS. I am inviting Dr. Shikha to present the clinical summary.
Good afternoon. I'm Dr. Shikha, CTVS resident. So, this was a 7-day-old male child of 3.5 kilograms. He presented with pulsatile swelling in the epigastrium and umbilical region since birth. He was a full-term normal vaginal delivery and appropriate for gestational age. There was meconium-stained liquor. Baby did not cry immediately after birth, and he was intubated in view of poor respiratory efforts and lethargy, and was referred to higher center. From there, he was taken to a private hospital and extubated on day 2 of life, and referred to AIIMS for further evaluation. On examination, the child was active and alert with a heart rate of 130 per minute, respiratory rate was 45 per minute, and capillary refilling time was less than 3 seconds. His blood pressure was 74 by 45 millimeters of mercury and saturation 98% on room air. All peripheral pulses were well palpable. On examination, there was a pulsatile mass extending from the epigastrium to umbilicus with a palpable bruit. It was contracting synchronously with cardium. There was hypoplasia of xiphoid process. This is the clinical video in which we can see the pulsatile mass. On cardiovascular examination, apex beat was not well palpable. The first and second heart sounds were normal, and there was a grade 3 ejection systolic murmur on the left sternal border, and bruit was heard all over the pulsatile mass. Respiratory examination was essentially normal. The child had good cry tone and activity, and there was no organomegaly. ECG showed normal sinus rhythm. Now may I invite Dr. Nabil to discuss on the echocardiography findings.
So we performed a transthoracic echo for this patient. This is the apical 4-chamber view, which is showing. Sorry, it's not playing. Showing this is the left ventricle, this is the right ventricle, and there is a large perimembranous VSD. You can see an extra flow which is coming at the apex of the ventricle. So we went to the subcostal view. There you could see a there was a diverticulum which was arising from the LV apex and with a to and fro blood flow into the diverticulum. So this is another view from the subcostal
plane which shows a LV diverticulum at the apex, which is extending caudally, and there is a to and fro blood flow into the diverticulum. So we did an ultrasound immediately. So this is the image showing a sagittal plane which showed LV. This is the LV cavity, LV apex, and this is the diverticulum which is traversing caudally through the anterior abdominal wall. So, and this is a video of the ultrasound we did. So here this is the left ventricle, and you can see tracing this downwards, it is extending downwards through the along the plane of anterior abdominal wall and is slowly moving and more anteriorly to the skin plane. Now I'll invite Dr. Apratim from cardiac radiology to discuss further.
Thank you, respected teachers. These are the reformatted, 3D reformatted CT angiography images done for the child. This image shows the diverticulum coming from the left ventricular cavity and extending downwards. And this is the appearance of the, if we have these soft tissues, so we can see there is a defect, and it is the diverticulum which is coming out, and if we subtract the soft tissues, so this is the actual imaging anatomy inside. These are the actual CT images. So this is a sagittal reformat. So we can see the diverticulum from the LV coming out through a small diaphragmatic defect and extending downwards. And these are the actual images. So we can see the defect in the abdominal wall here. So there is a gap. So this is the contrast filled diverticulum. So this one, and at the abdominal level, there is also a bowel coming out through this midline abdominal defect. We'll give to Dr. Shikha.
Thus, we made the diagnosis of Pentalogy of Cantrell with left ventricular diverticulum and a large perimembranous VSD with midline abdominal defect and anterior diaphragmatic hernia with omphaloceles. So, to discuss the surgical principles, it's very important to decide how we are going forward. The role of interdisciplinary approach, team approach is very important in this setting. So we have to decide whether we want to go for a single or a multi-stage procedure, which depends upon the associated intracardiac and abdominal defects. So the routine approach, which is described in literature, is the midline sternotomy. And in our case, we went through a subxiphoid incision, as in the current case, we were not intending to do any intracardiac repair. So by doing the sternotomy, we could have faced the post-op issues, like there could be difficult respiratory compliance. And thus, to tide over the crisis, we went through a subxiphoid approach. Also, the abdominal rectus defect was there present in our case. So we dealt with it in the same setting. So this is the surgical video of the patient. We started with a subxiphoid incision. So as we can see, there was a divarication of recti. The rectus sheath was not formed in the midline. So here we are dividing and we are dissecting the diverticulum from the surrounding structures. So here superiorly we can see the diaphragmatic defect. So we are freeing the diverticulum here. And we have taken a vessel loop across to take the control. And here we have taken a clamp in which we have taken the proximal control and decompressing the sac, and we passed a tie So here we are taking 3 of felted sutures to deal with the proximal part. So after taking the three sutures, we divided it. And then the diverticulum was divided in between, and then the diaphragmatic repair was repaired with 3 sutures. Here we can see the diaphragmatic defect being repaired. Now I would like to invite Dr. Krishnan from Pediatric Surgery Department to describe the further part of the surgery.
So after the diaphragm was repaired, we approached the omphalocele sac. So So now there is a sac which is covering the omphalocele. So the bowel contents had got reduced in the anesthesia itself. So we gradually separated the sac, and then the sac was ligated. Following the ligation of the sac, the abdomen was closed primarily, and in this, since a small omphalocele, the primary closure was done easily. But we should watch out for abdominal compartment syndrome in case of giant omphalocele, and in this case, there were no features of any compartment syndrome.
So this is the final image. Now I would like to invite Dr. Surbi from Pathology Department to discuss the histopathology.
Good afternoon. So we had received 2 samples. Specimens. First was the left diverticulum specimen, and it was a single tubular structure measuring 4 centimeters in length. These are the cross sections, and here we can see that it is a true diverticulum comprising of all the 3 layers. This is a slightly high power. The endocardial layer was unremarkable. There is focal disorganization of the cardiac muscle bundles with focal fibrosis. This is higher part of the same, and Mason's trichome strain highlights perivascular fibrosis with mild disorganization of the cardiac muscle bundles and fibrosis. The second specimen we had received was the umbilical hernial sac. So the overlying skin was mildly hyperkeratotic, and in the deep dermal tissue there were bundles of cardiac muscles with few thin-walled dilated vascular channels. So these were the vascular channels which were there. Along with this is the high power of the same cardiac muscle bundles. And along with this, there was chronic inflammatory infiltrate, which was eosinophil rich, and at places neutrophils were also there. So on histomorphology, we gave a final diagnosis of diverticulum of the endomyocardium, which was deep dermal in location.
So the child was extubated on day 1 post-surgery and was discharged from hospital on day 7. So what literature says, I'll just brief it out. O'Brien first described the left ventricular diverticulum in 1838, and the prevalence is 0.4%. So the diverticulum, it is most commonly apical, and it can be non-apical also in 30% of the cases. Most of the apical diverticulum, they are associated with the midline thoracoabdominal defects, umbilical hernia, and complex congenital cardiac abnormalities. And the non-apical diverticulum, they arises from the subaortic region, the anterior free wall, or rarely from both the ventricles. So the essential part is that a ventricle outpouching from a ventricle, which contracts synchronously with of the chamber, and histologically it contains all three layers of the ventricle wall, that is endocardium, myocardium, and pericardium, is a true diverticulum. And embryologically, the developmental disturbance in the mesoderm can cause this diverticulum, and there could be partial cessation of ventricular embryonic development. So, syndromic association was well described by Cantrell in 1958, and the Pentalogy of Cantrell, as we say it contains defect of heart, pericardium, diaphragm, sternum, and abdominal wall. It can be complete or incomplete. So, etiology, it is most commonly sporadic, but some familial cases have been reported. It is 1 in 65,000 live births. The cardiac defects include ventricular septal defect, which is most commonly seen. Other defects are ASD, pulmonary atresia, left ventricular diverticulum, ectopia caris, PTA, or tetralogy of Fallot. And abdominal wall defects, they include omphalocele, abdominal diastasis, and gastroschisis. Sternal defects could be complete absence of xiphoid, that is, it can lead to ectopia cordis, or complete absence of the sternum. Our case had only hypoplasia of the xiphoid process. There can be cleft sternum or short sternum. And diaphragmatic hernia is also associated with Pentalogy of Cantrell. There could be pericardial defect also. So other associated defects include craniofacial abnormalities, hypoplasia of lung, kidney, adrenal, and liver, malrotation of gut, and limb defects. So why surgery was necessary for this case? It is reported in literature that 70% of the cases which are presenting in the neonatal period, it can cause spontaneous rupture. Other things are embolic events, which are associated with around 3%, arrhythmias, infective endocarditis, and heart failure. As there is scarcity of literature and the case is rare, there is no consensus on the treatment, and the plan has to be individualized. The perioperative mortality is around 7%, and outcome is good after repair. And again, the technique depends upon the presentation. The management, it involves the interprofessional team approach, which is very important, right from the neonatal resuscitation to the surgery and to the planning of the stage procedure. And as I said, the ventricular or ASD associated or the other cardiac abnormalities associated can be dealt at a later stage. And we should always avoid the high postoperative intra-abdominal and intrathoracic pressure following repair of the abdominal wall and the sternal defects. It is very crucial in the postoperative management. So prognosis, it mainly depends upon the associated severity of the intra and extracardiac defects. So this is the image of the child on 1 month post-surgery.
Thank you, Shikha. Since this patient had only VSD and we didn't plan to intervene any intracardiac repairs, we went for a minimally invasive type subxiphoid approach to just deal the main defect now and to repair the abdominal wall defects, and we came out after repairing the LV diabetes. But many cases which are written like they have sternal defects and it requires reconstruction if there's a major anomaly, or they go sternotomy, repair completely the cardiac defects, but we did the minimum and came out.
Basically, the excellent case. I want to ask about the LV function in the longer term. Is there literature
That,
in the long term?
Sir, usually, yes, sir. Usually, the LV geometry and LV function is a concern, and we are planning for the follow-up in this patient. In the ICU echo, it was normal LV function and LV geometry was good, but long term they follow and it matters. Long term. Sir, long term, it says usually during resection in the initial postoperative, the post-op echo shows the LV geometry is good and LV function. Late deterioration is very less times.
Congratulations on this case. I have a question on histopathology. Why were there eosinophils?
Pardon, sir?
Why were there so many eosinophils in the histopathology? How do you explain that? Does it have a bearing on the development or why are so many eosinophils?
Normally, you don't get neutrophilic response in your lymphocyte. But I presume there were, because I happened to see that case, there were quite a number of eosinophils, and maybe it is related to some drug which was given preoperatively. Because otherwise, eosinophilic endomyocarditis cannot be explained in such cases. Another part, did the child have significant arrhythmias? Because when I saw the slide, there's a lot of Purkinje cells also are mixed with the normal cardiac mass, so-called normal cardiac mass. So my query is, was there a history of arrhythmia in this child?
In this check.
It's the remaining diverticulum, which attaches to the apex of the LV and attaches to the umbilicus, pulls the down from the cervical region to thoracic region. If there is a Pentalogy of Cantrell, it can pull it down. So that is why usually it fibros, and then apoptosis happens, and the diverticulum ligament completely disappears. Sometimes in the proximal part, the LV it can stay there. So it is, I think, classically a case of remnant of the vernaculum, which is almost going to the umbilicus. And that is why there is fibrosis, there is inflammatory cell infiltrate, usually they undergo fibrosis and atrophy.
Congratulations. Okay.
Yeah.
My question is, did you remove the diverticulum flash with the LV myocardium, or did you leave a redundant?
Left a bit redundant part. We didn't go near completely resection. Usually it's not adverse because the LAD in apical diverticulum, the left anterior descending is very near to the diverticulum. So a part is bit left. So without damaging the LV and then resect. In the video it was shown. I think you can show the video. There's a part, minimal part is left so that we are not near the left anterior descending and we are not altering the LV geometry. But the last budgeted stitch which was taken was like it was at the base of diverticulum, but we left so that we can cut and transfix.
Continuing on the point regarding eosinophils, our blood hematology was all right.
Sir, unka pre-op there was yes sir, and it was grossly normal only. And let me check again. And there was no arrhythmia. And question was asked, there was no arrhythmia before in the child. It was normal sinus.
So I think in this case, we are calling it fibrosis. Probably it is hernia of the neck. And as it was described by you in this paper also discussion, the document diverticulum descends into the hernia of the neck. And there is no subtle defect. It's a very incomplete pathology.
Yeah.
There is an anterior pericardial defect, vertical activity, but there is no subtle.
Xiphoid was not complete. Only xiphoid was involved.
So I've had the experience of preparing a couple of these food pentology of Cantrell. The oldest one is now 15 years old.
Okay.
And I shared this experience where because 2 years after I repaired the sternal defect using this costal cartilage grafts, in this I was called upon by the cardiac surgeon to open the chest for the intracardiac repair. And you could see the surviving grafts, and if I would have moved this case before, I would have got pictures full, and we could see the ends of the pericondyl and all the condylar cartilages, and we could cut through it and repair it.
Okay.
The child had Pentalogy of Cantrell.
Okay.
1 year, 7 months after the primary repair, she underwent
Pentology repair. Stop. No sir, no need for any anticoagulation. We didn't use any prosthesis or anything. It's a normal. But that is not in the circulation. There has been taken out. We took a last pledgeted stitch also. No, that's not in part of circulation. No. Ma'am, usually congenital bulges can be either left ventricular aneurysms or diverticulum. And if it is a diverticulum, it involves all layers of the cardiac cells. So that puts our diagnosis more towards the LV diverticulum.
When do you propose to intend the BF?
Sir, as of now, it's very neonate. He's not having any failure features. We have to follow. We called him for 1 month follow, and then later, if needed. Yes, sir. In the initial post-op echo in the ICU, the screening echo didn't show any much changes. But yes, sir. If it is like, can close.
The diverticular diameter near the apex is quite big.
It was like
it's ligated. Most of the healing usually takes place for fibrosis. So later on, this patient might come with the fibrosis, aneurysm, and dilatation. and clot formation, embolic capacity, all these have to be monitored.
Sir, but once the resection is done complete, I don't think they should present.
That was actually a continuation from the left ventricle.
Yeah.
Even the endocardium is actually continuous with the left ventricle. We just did a ligation at the apex.
Yes, sir.
Ventricular apex. So that lesion cross surface, it has to be healed. So healing usually by fibrosis.
Yes, sir.
So the cardiac muscle will not regenerate as such.
Yeah.
So when there is a fibrosis as the child grows, the fibrosis component will also expand. So I think this has to be monitored.
I think that this will be something similar to any ventricular.
Yes.
Yeah.
That's all. It's going to be bigger than this.
There is the risk of arrhythmia.
As the child grows, the scar will remain smaller and smaller compared to the whole
The scar will be there distal to the ligation. So that will be ischemic.
That is ischemic.
The wall, the wall and the cavity and the hair will not have.
Sir, actually it is now separated from the circulation. As seen in the thing, the clamp is applied and the tissue, whatever you are seeing, is beyond the clamp. So it is not in line with the circulation, which should not. It is in continuation with left ventricle.
Yeah. Now what has been done is it has been now stitched. One stitch is there in the LV side where it has been exteriorated to the LV cavity. So if you look at it inside the LV, there is only one stitch is there, one line of stitch is there.
LV के अंदर कोई स्टिच नहीं है, LV के बाहर है.
बाहर ही है.
So basically, we have put a clamp. It was about 1.5 centimeters diameter. It's not like it. We have put a clamp and amputation, and we have taken 2 thickness pipes. So it's just like repairing any ventriculotomy after cardiac surgery. So it is just a ventriculotomy.
So one thing I would just like to observation that this for the heart failure, the recent advances which are going on, they are trying to develop a sheet of cardiac cells which can be contracting. Now this is a very unique opportunity. You have got this the muscle that you got is a full cardiac thickness. So it's a normal cardiac muscle which is redundant, extra cardiac muscle, which is never available to the to us.
Sir, ultimately either this will fibrose by nature or it will thin out.
Thin out.
It will not maintain because already the fibrosis process, inflammatory infiltration and apoptosis will happen. Either it will fibrose completely or it will thin out.
And may rupture also.
So imperial college, they develop this stem cell patch and you can go for patch.
Thank you.